expect 100% root coverage. So in this study, with connective tissue graft, 79% of the time we achieved 100% root coverage. With the coronally advanced flap and enamel matrix derivative, 90% of the time we achieved 100% root coverage. Again, both of those figures beat what you typically see in the systematic reviews. And then finally, healing pattern. Now this is something that we know that enamel matrix derivative, it has something that improves the process of wound healing, and this lateral incisor here was randomized to receive enamel matrix derivative. This is randomized to receive connective tissue graft. And let's just look at a head-to-head comparison as we move out in time points. Here it is at a week. Look at the connective tissue. I like this as a clinician because it's red and it's alive. I know this is going to work. But look at the inflammation, you know, the contours here, the swelling. Compare that to the contours we have at 1 week here. The less swelling, less inflammation. That continues out at a month. We still have more inflammation here than we have at a month and at a year. Now again, well, what do I think about this as a clinician? You know, even though, you know, we do a lot of clinical research, I make my living treating patients. This is my hobby. And so I need this stuff to work. And when I look at this, you know, I'll take this as a clinician every day, 100% root coverage. But you can tell I was in there. Compare that to this. You know, I could hand this slide to you and say this is a picture of health, that there's never ever been any recession here. And again, this is where I think we're wanting to move. We want to be able to go beyond just being able to correct these defects. We want to be able to correct it in such a way that you can't tell there was ever a problem there before. And then finally, perception of pain. And you can imagine, you know, which one you would prefer. Now, we also did, in this particular paper, we had a patient that had 2 hopeless teeth that allowed us to look at the type of attachment. This lateral incisor was randomized to receive enamel matrix derivative. This was randomized to receive connective tissue graft. And so this is our control. I'm just doing a little histologic marker with a quarter round burr at the free gingival margin. I create a partial thickness flap. I'm making my little mark here at the original alveolar crest. And we harvest a little connective tissue. We place it over our denuded root, coronally advance the flap, and here's what we have at 6 months. Now, we don't have 100% root coverage. This is a Miller Class 4 defect, so you wouldn't expect 100% root coverage, but not bad. So we're going to remove this tooth in block. This is how it looks like, and in very low power. This is our notch at the osseous crest, the original gingival margin, and this is the notch at the original alveolar crest. If we look at it in a little more high power, we see that our long junctional epithelium ends right at the superior border of the notch at the original gingival margin. We don't see any junctional epithelium down here, but we also don't see any regeneration. We have parallel connective tissue fibers, no new cementum. And as we go down to the base, here is our original osseous crest. We have a little, this is reparative cementum, this isn't regenerative cementum, but again, no evidence of regeneration here. Now let's look at what goes on with our enamel matrix derivative tooth. So I'm making my notch at the original gingival margin. I create a flap, and this is the notch, but it's really not at the osseous crest because this tooth had experienced an apicoectomy in the past. There was no bone at the apex. If we look at it radiographically, we can see, as you see with these teeth that have severe bone loss and apicoectomy, you know, the bone loss just wraps completely around the apex. You know, there's a reason this is a hopeless tooth. So really, you know, this notch is right there. It's at the end of the tooth, not at the osseous crest, because there is no osseous crest. And so we you know, do root preparation. We're placing our enamel matrix derivative on the tooth, coronally advance the flap. And at 4 weeks, we've got a dehiscence and a fenestration. So, you know, no, this is not a good news. This is my histologic marker full of plaque. It renders that useless. And so what we're going to have to do is we're going to come in and make all of our histologic slices here on the medial aspect. Now, just to remind you, there's no bone here on the medial aspect. You know, the bone loss wraps around as you see here, but the histology I'm just about to show you is going to come from that medial aspect of the tooth. So we'll remove that in block, and here's the tooth and low power, and we see we have all 3 tissues necessary for regeneration. We've got some new cementum, we have organizing PDL fibers and new bone, and when I saw that, I thought, wow, this looks so much like the illustration of the mechanism of action of the enamel matrix derivative. Now, remember I said collagen forms at a fixed distance from the root surface. It mineralizes in the attachment apparatus, so you can see islands of condensing bone at a fixed distance from the root surface. And I remind you that you get that type of regeneration only one time in nature, and that is when the tooth is being developed. You get the bone that's growing at a fixed distance from the root surface, the attachment apparatus occurs, and then it fuses to the maxilla or the mandible. Now, all other forms of regeneration are an extension of the alveolar crest. So although we lost our histologic markers, and that throws in some, I can't say with absolute certainty, but I can suggest that there's something very different going on here. Same patient, same surgeon, same day, yet you can see something clearly different happening here, and I think at the very least it serves as proof of principle of the biomimetic nature, the mechanism of action of enamel matrix derivative. I also will suggest to you that you're probably going to see a resurgence of interest in enamel matrix derivative for two reasons. One is it's back on the market. Two is because there is a new systematic review out showing something that no other systematic reviews have shown. Both the European Federation of Periodontology and the AAP periodically do systematic reviews. And one that was just done and it is coming out in a supplement of the Journal of Clinical Periodontology. I don't know that it's out yet. Don't think it is. Authored by Cairo, and it's a systematic review, treatment of gingival recession with coronally advanced flap procedures. And what they concluded was that connective tissue graft or enamel matrix derivative in conjunction with the coronally advanced flap enhances the probability of attaining complete root coverage in Miller class 1 and 2 recessions. No other systematic review has come to that conclusion. So that's a pretty big change. All the other systematic reviews say that adding anything else to connective tissue graft didn't seem to make a difference. So for those two reasons, I think you're going to see a resurgence, more interest, more papers coming out using enamel matrix derivative. Well, what happens what if we use the cells I showed you and we use biologic mediators to try to direct the cells into the activity we want? That kind of makes sense. Well, we were part of a small animal study that David Cochran's group in San Antonio did, in which we used the living human fibroblast-derived dermal substitute along with enamel matrix derivative. It was a baboon study. Surgical defects were created. And we had class 3 furcations, randomized, receive an open flap debridement, enamel matrix derivative, or the human fibroblast-derived dermal substitute, or a combination of the two. And we looked at it 6 months later. So here is the defect following healing, and you can see there's ligature here just to make sure there's no spontaneous healing. You can see that the baboon's not doing a great job with daily home care. And anytime you're looking at animal studies and where they're creating furcations, you want to make sure that they don't leave the bone interproximally, and here obviously that wasn't done. And so this is just debriding the defects. Now the enamel matrix derivative is being placed into here, placing a little more EMD here. And now we're going to enfold this living human fibroblast-derived dermal substitute into the furcation. So it's just kind of been enfolded in there. And now we'll place another sheet on the outside like you would with a traditional guided tissue regeneration membrane. Now on the tooth next to it, if you look closely, you can see we've enfolded the cells into that furcation, but we're not going to place EMD here. This will be just the cells. And now we place another layer here, and then the tissue is coronally advanced. And here's what we have. With control, here's our notch at the osseous crest. And control is just healing, no regeneration whatsoever. Here, the notch is down here. Here's the human fibroblast-derived dermal substitute. You can see improved regeneration into the furcation as compared to control. And here's the combination of the MD and the human fibroblast-derived dermal substitute. In this one, we don't have any epithelium and have more regeneration of the furcation. There were a number of problems with this study. A lot of there were some technical problems with the histology, and really you couldn't really say much as far as results. I put it in here just again because I think that this is something that we're going to be seeing more of. We're going to see placing cells, but directing them into specific activities that we're looking for. I want to end with staying on the biologically active mediator side end of the tissue engineering matrix But I want to talk about using platelet-derived growth factor and beta TCP. Now, we did a pilot study that you may have read in International Journal of Permanent Restorative Dentistry in 2006, comparing using the PDGF and the TCP compared to connective tissue graft. A small study. We were looking at our primary efficacy variable was absolute change in recession depth, but we also looked at clinical attachment level, broken pocket depth, amount of keratinized tissue, and all the normal things you would look at. When we evaluated these at baseline 3 and 6 months, there were no differences in any of these parameters at baseline. And when we looked at them at 6 months, we found that there were some positive changes that I'll report on in just a second. Here you again get a feel for the type of defects that we enrolled into this study. Again, fairly broad, deep recession defects, not small defects. This will be our control. And here I have a partial thickness flap. You see I've got my connective tissue over the root surfaces here. I'm going to coronally advance my flap over the connective tissue. And here a very nice result at 3 months. Again, we haven't, because it's in a study, I haven't gone in and plastied or touched it up or anything like that. You know, a very pretty connective tissue graft, 100% root coverage on both of these teeth. This happened to be the test tooth. Now here, same patient, opposite side. This will be I'm sorry, that was a control tooth. This is our test tooth, fairly wide, deep recession, and we will go in. And in this case, we're going to do not a partial thickness flap, we're going to do a full thickness flap to about the point where 2 to 3 millimeters apical to your osseous crest. Then I go into a partial thickness flap. And we go in, we root plane and scale. We'll actually do that prior to doing our flap. Now I'm placing some platelet-derived growth factor here on the root surface. And we've hydrated the TCP with the PDGF, and we're placing it on the root surface here. But I must have been brain dead at on that particular day, and proudly taking pictures of my brain deadness, in that you can see I placed the TCP right to the CEJ. Obviously, you don't want to do that. You know, you want to leave room for your biologic width. So do it as it is in the illustration, not as I show you here. You know, you want we want this just extending 1 millimeter or so laterally onto the bone, and we want to leave 2 or 3 millimeters from your CEJ to the material here. And in the pilot, we were using a cell-occlusive membrane. This is the membrane, and just showing the difference in width between it and the control connective tissue. By the time we had finished the test, the pilot study, there was data coming out that, you know, you may not want to use a cell-occlusive membrane when you're using PDGF. Don't think of PDGF as guided tissue regeneration or guided bone regeneration. PDGF needs access to the periosteum, to the blood supply, to the cells. And so we now only use membranes if you need to somehow, if it's not a self-containing defect. And if you need a membrane, you want something that goes away very quickly. So we're using like collagen wound dressings, that kind of thing, not cell-occlusive membranes. So here is that membrane. I've then hydrated it with PDGF, and we close the flap. And here's our result at 3 months. Again, an excellent root coverage, very pretty, nice contours, 100% root coverage, no visible signs of inflammation. And if we compare at 6 months, the test at the control, a very nice end result on both connective tissue and the root coverage with the PDGF. And just to show you another of one of the patients in the study, this is connective tissue graft, and this is the PDGF graft. Again, note how much more natural that looks. It doesn't have that kind of straight line that you would expect from a connective tissue graft. And our conclusion to the pilot was that both procedures predictably achieved root coverage, and at the end of 6 months, all patients tested control had no more than 1 millimeter residual recession. All tissues appeared healthy and stable, and the test grafts appeared less bulky and more aesthetic. And the case series demonstrates proof of principle that it's possible to treat recession-type defects with PDGF and TCP and a collagen membrane, and the results support the need of a properly powered clinical study to determine, can we really do that? And then we took this then into a larger study, and we used lessons learned, and we changed our technique a little bit on the bigger study. In this study, we're again simply trying to compare it to connective tissue graft, and this is a two-part study. We're going to look at your typical clinical parameters, and we're also going to look at attachment. Because I think as we're moving in these biologically active mediators, we need to ask ourselves, what is the value added here? Because we know we can cover roots. I can cover it all day long with all sorts of things. But you have to ask yourself, what are these other materials providing that we can't achieve through connective tissue graft? So this study we're looking at clinical parameters, but I think very, very importantly, we're also going to look at the type of attachment that we're going to get on the root surface with the PDGF, because we have both light microscopy and micro-CT that I'll show you in just a moment. So if we look at the clinical parameters, a 30-patient study, 6 months, this study is completed. We've already submitted, there's going to be 2 papers. We've already submitted the paper to International Journal of Perirestorative Dentistry, and we're also going to submit the bigger paper to Journal of Periodontology. It should be submitted within a couple of weeks. So we have 30 subjects, 6 months patients. Our primary efficacy parameter was recession depth, and you can see the type of defect that we have here. In this study, we decided to mark the CEJ with a pencil. It just makes it easier to see photographically. Secondary efficacy parameters, clinical attachment level, probing depth reduction with the keratinized tissue, percent root coverage, color texture, aesthetic satisfaction, pain and discomfort. Now, when we look to see what is statistically different between the two, these were the only parameters that had any statistical significant differences between the two. The recession depth, in other words, how much root surface are you covering, and I think it means the same thing, but a more meaningful thing is percent root coverage, came out in favor of the connective tissue graft. We got almost 99% root coverage with the connective tissue graft to 91% root coverage with the coronally advanced flap and the PDGF. Problem is, we're doing so many of these studies, I'm just getting too doggone good with these connective tissue grafts. Because again, think back to what you would expect on the meta-analysis. Systematic reviews would tell you that you should be getting 89% root coverage with connective tissue grafts. So if we're getting 89% root coverage, well, this is looking really good. And again, think back to systematic reviews would tell you with just your coronally advanced flap, you should be able to be getting about 82% root coverage. So we are way above 82% here with 91% root coverage. So I think you need to couch that with it. Also, though, if you look at percent root coverage and then you look at aesthetic satisfaction, the patient says they're the same. You know, I think this is another area that you're going to see in future studies. We're going to be doing much more composite indexes as our primary efficacy parameter, because it is naive of us to think that percent root coverage is an appropriate surrogate for patient satisfaction. Almost all root coverage, even the systematic reviews say that the reason you do root coverage procedures is because of patient desire. Not health, patient desire. So, if that's the case, there's a lot of factors that go in here. Why are all of our patients saying that they're equally satisfied? And here one's almost, 10% different than the other? Well, for one, our patients may not be as anal as we are, but also they're looking at a lot of other things. They're not just looking at the amount of root coverage, they're looking at tissue thickness. Is one more bulky? Is one less bulky? They're looking at color, they're looking at texture. They're looking at the amount of improvement that they had before, what they had before. So a lot of things go into this. So I think in future studies you're going to see less of the primary efficacy parameter being recession depth. You're going to see composite scores that are going to be more appropriate to what the patient really wants. So that was interesting, and we're seeing that more and more. If you look at cal gain, they were identical. If you look at probing depth reduction, it actually favored the PDGF slightly. With the keratinized tissue, same. And pain and discomfort favored the test, as you would imagine, because you don't have a palatal donor site. So if we look at, here is our patient, and I'll show you a little video in a moment of how we did this technique. Again, we're in this study marking the CEJ with a pencil, a fairly broad, deep defect, intraoperative measurements. We do a full thickness flap, 2 or 3 millimeters beyond the osseous crest. I'm placing the PDGF onto the root surface here, and you want to make sure you've already hydrated your TCP at least 10 minutes prior to placing this on there. And you can see that I learned something from the pilot study, that I'm placing the material about 2 millimeters from the CEJ. You want to leave room for your attachment apparatus here. And also, this is the illustration I showed you from the pilot study, and you can see that we now feel you need far less TCP than what we had initially. You only want enough there to keep that membrane from collapsing onto the root surface. So, you know, probably the fewer particles you can place there just to keep the membrane off the root surface is what you want. Now, the TCP is physically filling the defect, is preventing the tissue from collapsing in. It also facilitates the stabilization of the blood clot, but it's just a scaffold. The star of the show is the PDGF. You know, this is a purely synthetic cell-signaling growth factor. We know more about this particular growth factor than any other growth factor in periodontics. It's chemotactic for the PDL and bone cells and mitogenic for both. And it's also angiogenic. It stimulates osteoblasts to produce VEGF and all sorts of other things that stimulates angiogenesis, which we've talked about as being important. So in this study, unlike the other one, we didn't use a cell-occlusive membrane. We just used a collagen wound dressing. And so this is going to go away very quickly. I'm hydrating it with the PDGF as well. And so here it is hydrated. I then close the flap and I place a little more PDGF on the surface because it, like EMD, stimulates wound healing. And so I'm placing that on the tissue to stimulate wound healing. We place our sutures. Now, this is not a passive graft. This is an active graft. And the PDGF causes the cementoblast to migrate into the root surface, begin producing cementum. Osteoblasts are coming in, fibroblasts are moving in, and endothelial cells beginning to create attachment apparatus over time. We have cementum being laid down on the root surface. We have our osseous crest being extended by the production of bone, and we see that we've got a organizing PDL, and finally attachment apparatus. Now, you know, we can all draw these illustrations. I'll show you some histology in just a moment that is real evidence of what's going on here. So here is a little video of the procedure itself. First, we're going to come in and we're going to root plane and scale before we do any sort of flap, and I'll use, as you're seeing here, a chisel. I'll also come in with just, you know, whatever it takes. You know, curette, if I need it, I'll come in with a high-speed finishing burn. You know, whatever I need to make certain that I have a biologically compatible root surface. I'm not really trying to necessarily bring it into the alveolar housing. I just want to make sure it's nice and clean. We routinely, you know, we don't do it in the study, but we routinely remove class 5 restorations and, you know, are grafting over these previously restored areas. We're using, this is tetracycline, or as a biomodifier on the root surface, just to remove bacterial smear layer, and irrigating that with some sterile saline. And now just going to come in, make 2 divergent incisions on the mesial and the distal of the defect. Computer is extra slow today. At least it's running. And now we'll do an intrasulcular incision, just freeing up the papilla areas, and I'll do an intrasulcular incision.